be chemical, it can be anything. Keeping the things or environment in a steady state so that you're not fluctuating between two ends, high and low, okay? Because as living beings, we need a steady state to maintain or sustain the life. The main reason is because we need optimal states, conditions to maintain our functions. Why? Because we are based on functioning enzymes and they need good temperature, good pH, everything. They need everything to the point. So we need to maintain this steady state or the homeostasis. So when it comes to the acid-base homeostasis, we maintain it at 7.35 to 7.45. And the main reason being it can affect lot of enzyme activities and other channels, ion channel activities, and even other hormones. Hormones can be affected by the acid-base status of the human body. And the important thing is it's maintained at a very narrow range. Therefore, maintaining it at the physiologically favorable narrow range can be challenging. And let's look at what's the difference between the H+ concentration and the pH. So pH is the inverse log of H+ concentration. Actually, sorry, not inverse log. Log of inverse H+ concentration. So inverse log would be different. And here, so do you appreciate that we are talking about log values? So since we are talking about log values, we are talking about 10-fold changes. So if your acid, if your pH is changed by 1 unit, there would be a 10, that is because there is a 10-fold concentration change in the H+. So it is a significant difference. So 10-fold change, that's large. Now, if you look at the 30, like if your pH, if your H+ concentration is 35 nanomoles per liter, and that would translate to pH of 7.456. So you look at the log table, you'll get this value. So I'm not going to go through the mathematics of it. I want you to just appreciate the difference between these two values. Now, next, your H+ concentration, if it is increased by 10 nanomole, if your concentration is now 45 nanomoles per liter, the pH would drop down to 7.347. So here, the difference between the pH and the H+ concentration you need to appreciate, because if there is a small pH difference, that is because of a large difference in the ion concentrations. So that is why it can affect a lot of systems and why it can significantly affect. Now, how do we maintain this acid-base homeostasis? That is by using buffer systems. So we have buffers that would prevent the change of H+ concentration by binding with the H+ or releasing H+. So they either take up or release H+ depending on where the pH is going. So the main function of a buffer system is to resist changes in the pH. But that is only if there is only small amount of acid or base is added. So if it's a large amount that is being added, then your buffer systems will fail and your acid-base status will default and will become pathologic. That means you might get acidosis or alkalosis. So this is just a small recap on the Henderson-Hasselbalch equation so that you can understand or logically see which part goes with what component. So you see, based on the Henderson-Hasselbalch equation, your pH is directly proportional to the bicarbonate, whereas it is indirectly proportional to the PCO2 or carbon dioxide. Therefore, keep this in mind that your pH would be directly proportional to the metabolic component, whereas pH would be indirectly proportional to the respiratory component. That means if the PCO2 is rising, pH would be falling because it's indirectly proportional. So when you say indirectly proportional, so if the pH is increasing, your PCO2 should be actually falling, okay? But with regards to the bicarbonate, the metabolic component is directly proportional. That means if pH is increasing, then bicarbonate is increasing, okay? Okay, so I need to get rid of that. Now, let's recap these buffer systems. Again, you have learned, but let's recap them to make sure that you have a basic understanding. So one of the main buffer systems is carbonic acid bicarbonate buffer system. It's the most important extracellular buffer, and how you get it is by carbon dioxide binding with water. So you have lungs eliminating carbon dioxide that would determine the bicarbonate concentration actually. And kidneys would help by maintaining the bicarbonate concentration through reabsorption at the tubules. Usually the body wants to keep more bicarbonate in the system because we anyway produce acids when during our metabolic function. So we produce acid in our day-to-day activities. Therefore, we want bicarbonate or bases to neutralize those acids. So body maintains 20:1 ratio of bicarbonate to carbonic acid usually so that you can buffer excess H+. Next, okay, what's wrong with it? Next, another major buffer system is the proteins, plasma proteins, including albumin and also hemoglobin and any other cellular proteins also would contribute to it because you know the most proteins are called, they are sweet ions. They can bind with an acid or a base or hydroxyl group. Therefore, they can bind with H+ or give H+ where needed and help with acid-base homeostasis. Now, this will also affect other ions. Can anybody remember any ions that are being affected when the acid-base status changes in the blood and it affects the proteins? Anybody? No? Calcium, do you remember calcium? What happens to calcium when you have alkalosis or acidosis? because calcium is bound to albumin. Anything that is bound to a protein will be affected if they are going to bind with H plus in return. So calcium, you get hypo or hypercalcemia, mostly hypocalcemia in alkalosis, because you're going to release H plus, and to maintain the acid-base homeostasis, which will create space for the calcium to come and bind. So leading to spurious hypocalcemia. Next, you have phosphate buffer. It's mainly intracellular buffer, and it is also present in urine, which would increase the net acid excretion. And then ammonia buffer, again, a major renal or urinary buffer, which will help you excrete more acids by binding with the H plus and forming ammonium ion, and then you can put it out without having so much acidosis in the urine, and you can continue to put the acids out. So when we look at these buffer systems, you can divide them as chemical and physiological buffers. The chemical buffers act fast. Therefore, they are called first line or first line defense mechanisms, or first line to act when there is a pH shift. Those include the bicarbonate, phosphate, and proteins, because they are at the first line when there is any changes to the acid-base homeostasis taking place. The second line mechanisms that will come into play include other physiological buffers that need to make some changes in their system to help. So for example, one is respiratory mechanism, where you would change the carbon dioxide excretory pattern to help maintain the acid-base homeostasis. Either you can slow down the respiration so that you will keep some carbon dioxide. You can continue to do that because you can't keep all the carbon dioxide in. So there is limit that you can go for. But you can do something to keep some carbon dioxide in by slowing the respiratory rate down if there is alkalosis going on in the body. And the renal mechanism would be based on the H plus excretion. The renal mechanism, the kidneys can increase the H plus excretion or decrease the H plus excretion, mostly increase the H plus excretion, and help the acid-base homeostasis. So these two functions need time to act. Usually we call within minutes these chemical buffer systems come into play. Within hours, respiratory mechanisms come into play. Within days, renal mechanisms will come to play. So let's look at these compensatory mechanisms. So in the lungs, you excrete carbon dioxide. It's quite powerful way of expelling acids, because carbon dioxide can be put out with the effect of the lungs, and this is also very useful in volatile acids, where you don't need to you don't need the help of carbon dioxide. You can just put the acid out. Any acid come to mind? Anybody? No? Diabetic patients, any volatile acid come to your mind? Yes? Diabetic patients, any volatile acid? මතක් වෙන්නේ? You have done medicine appointments, right? Yes. Very good. Keto acids. So any specific keto acid? Excellent. Good. So thank you. So I expect your answers like this. So you can unmute and answer as well. Any specific keto acid? Find that out. Find out which keto acid you can expel in the respiratory system. So certain acids cannot be affected cannot be helped by the respiratory mechanisms, but this is one major mechanism. The other one is the renal mechanism. You can eliminate large amounts of acids in the urine, and this is not only to excrete acids, but you can also excrete bases as well. But mainly it's the acids often, because that is where we end up going most of the times. However, you can use both. You can use it in both instances. You can put out acids and bases as well. So here you have phosphate buffer and the ammonia buffer, which will help excrete acids. And this is slower than respiratory because it takes several days. Now, rate of action. Usually they come into play instantly. The chemical ones within minutes, the respiratory within hours, and renal within days. Okay, so now when we talk about acid-base disorders, so we looked at Henderson-Hasselbalch equation before. So you see the pH will give you what is happening at the end, what is the end result, what is the final result of the acid-base disorder that is happening. So it is the result of metabolic and respiratory interplay in your body. And as we first looked at this, if you're having any alteration in the metabolism part, that would be affecting the bicarbonate, so which is the metabolic component, and it would be directly proportional to the pH. Whereas if there is any respiratory disorder which will affect, that would be the respiratory component, which will be indirectly proportional to the pH. Okay, and so acidosis would be if your pH is less than 7.35. Alkalosis would be if the pH is more than 7.45. So it's going in opposite directions. And don't get confused in identifying acidosis or alkalosis, and make sure you read the question and write down the correct answer when you answer the question paper, because I encountered several where, you say pH is increasing, but you're saying acidosis. If pH is increasing, that is alkalosis, okay? So you need to get that into your head properly. You can create a mnemonic or anything, any way to remember that. And if one component is playing bad, the other component will come to compensate and help. However, you need to understand compensation never overcorrect. What it means is that, so if you're having metabolic acidosis, your metabolic acidosis will never be overcompensated and go into respiratory alkalosis by respiratory compensation. Okay, so it will come down to normal, but it will never go overcompensate. Okay, so let's start with metabolic acidosis. So what is metabolic acidosis? So acidosis means you're having excess acids. So if you're having excess acids due to metabolic component, that means your pH would be directly proportional to the metabolic component. Therefore, your pH would fall. So what should I do? I think I'm going to do this. I don't think I can. Okay, so let's do the lecture like this, because that way I can easily do this. Okay, so here, now, if your metabolic component is going, if your metabolic component is the affected, it would be directly proportional to the pH. And here, if it is metabolic acidosis, what will happen? Bicarbonate it's a base. So bicarbonate is a base itself. So bicarbonate level would be falling, right? Bicarbonate level would be falling in metabolic acidosis. So pH would be falling because it is directly proportional. So your pH would be low. And here, the reason would be mostly either you're producing excess acids, which are mostly organic acids, such as lactic acid or keto acids, or your kidneys are failing to excrete H+. Or you can lose bicarbonate in some other way. Any ways that you can lose bicarbonate? Yes. Any ways that comes to your mind? In diarrhea. Yes. Okay, I got it. Oh, vomiting. So vomiting, in vomiting, what do you lose? Where do you get bicarbonate? Thank you for that answer. But where do you get bicarbonate? You get bicarbonate from the pancreatic juice into the duodenum. So it's less likely you can get the duodenum content in the small intestine out through your mouth. Not impossible, but not usually. In the gut, in the stomach, what do you have? You have acids. So you will expel or put out acids in vomiting, but in diarrhea, you will lose bicarbonate. So vomiting will lead to metabolic alkalosis actually, because you're losing acids, okay? Okay, so here, what you're going to get is a bicarbonate deficit. Next, let's also look at what are the common causes of metabolic acidosis. So increased H+, ketoacidosis, lactic acidosis, there can be poisoning. Very common ones are ethanol, salicylate, ethylene glycol. So you can create mnemonics. There are mnemonics. You can find them out. And any organic acidosis associated with inborn errors of metabolism. And you can lose bicarbonate in diarrhea. Or there can be pancreatic fistula. Or in renal, proximal, yeah, type 2 RTA, proximal renal tubular acidosis. Why? In the glomerulus, you have the proximal tubule is the one that is going to reabsorb bicarbonate. And then loop of Henle and the distal tubule, where distal tubule is where you are going to excrete H+, right? That is, we are going to excrete H+, whereas here you are going to reabsorb bicarbonate. Therefore, in RTA type 2, you get you get a metabolic acidosis because of losing bicarbonate. And then you can have decreased H+ excretion, where your renal functions are affected, or mostly it's because of the renal functions are affected, and how renal functions are affected can be different. One is renal failure, and you can have distal renal tubular acidosis. That is what I just said. And then other poisonings, or actually it's drugs that will prevent or inhibit acid excretion. And funnily enough, the Addison's and mineralocorticoid deficiency. So Addison's disease, what happens there? So you don't have enough cortisol that will lead to, indirectly lead to H plus buildup. That is because your H plus excretion is linked with the action of the cortisol and cortisol action and the action of the mineralocorticoids on renal tubules. So that you need to look at. We don't have enough time to discuss everything. What is the mechanism? You need to look at that. Okay. So how is this compensated? If you're having metabolic issue, the compensation is by the respiratory. So if you're having metabolic acidosis because you are building up acid, either because you cannot excrete or you are producing more or you're losing bicarbonate. So that's how you remember. So you need to understand how you're going to get acidosis. Either your production is increased or your excretion is decreased. Or the other thing is you're losing the other one, which is the bicarbonate, H plus and the bicarbonate. So either you're losing bicarbonate or having excess H plus. So in this case, the kidneys, the lungs, what would they do? They can expel more carbon dioxide out and help the system to get back the acid-base status back to the normal. And the main compensation would be through the kidneys. So how do you excrete more carbon dioxide? Yes. How would you do that? Through lungs. You need to your respiratory rate need to increase. Yes, very good. Hyperventilation. So by increasing your respiratory rate, you can expel more carbon dioxide. But can you go on doing that forever? Can you can you fully compensate? Is that possible? Yes. It's not possible. Why? Because your respiration is also driven by carbon dioxide. So you cannot continue to expel carbon dioxide like that to get everything down to completely to normal, because at one point you will stop being able to use that as a drive. Otherwise, because your respiratory drive will go off. Therefore, you cannot continue to do that. And there is a limit that you can compensate. So similarly, the other way, we will discuss that when it comes to it. So you cannot continue to increase your respiratory rate to get rid of all the ions. Now, when we talk about acidosis, there is a thing called anion gap. What the hell is this gap? So what is this anion gap? Now, what are anions? Anions are the negatively charged ions. So how do you get this anion gap? Yes. Can you have a gap? Actual gap? No. You can't. In your body, everything is in equilibrium. Although the homeostasis can change, everything's in equilibrium. You're not actually having a gap. It's just the measurement gap. So if your system is producing more acids, you will end up having organic acids. So these organic acids are going to produce certain anionic groups that are not measured. So the usually measured anions include these, the chloride and bicarbonate. And the main cation is the sodium. You also have potassium, I know, but its concentration is so low compared to sodium, you can disregard it actually here. Now, since you're going to produce now H plus here, you are going to have more any kind of, I'm going to just write COO, carboxyl, COO minus, or any kind of organic acid anions. So you will have those. So those ones you're not going to be measuring. So that's why you're going to have this anion gap, because you're not measuring those. However, they are there. And when you measure the sodium and the usual anions, you are going to see there is a gap. And that gap, excess gap, is due to the organic acids that have been produced due to whatever the pathology that is going on in the body. So here, normally you have this anion gap of about 12 millimoles per liter, which is due to plasma proteins because they are usually negatively charged. And if you're having metabolic acidosis, you are going to have excess anions coming in due to these organic acids, and those are going to take place of the anion area, and you're going to see higher anion gap. This is useful to diagnose metabolic acidosis, especially because in metabolic acidosis, you are going to lose this. You're going to lose the bicarbonate. Since you are losing bicarbonate, your bicarbonate level will go down and your anion gap will increase. So how do you differentiate based on the anion gap? You're going to have an increased anion gap when there is production of organic acids or difficulty in excretion of organic acid, as in renal failure. All the others are increased production of organic acid. And when are you going to have normal anion gap? That is when you are not producing any excess organic acids, right? So you're losing bicarbonate, but you're not having any acid coming in. Therefore, you're going to have normal anion gap in these instances, diarrhea and renal tubular acidosis. And I'm going to ask you to read about base excess. What is base excess? That's an interesting concept to understand related to metabolic acidosis. Next, respiratory acidosis. How do you get respiratory acidosis? That is when you are unable to excrete the carbon dioxide. Why? Because if you excrete carbon dioxide, will lead to carbonic acid. And how do you work this out? That is, why is it not working? Okay, so that is because if the carbon dioxide is increasing, what is going to happen? pH should be decreasing. Why? It is indirectly proportional. And you're going to add acid, so pH should be decreasing. And that will lead to respiratory acidosis. And the reasons why and when you get respiratory acidosis. These can be either acute or chronic. In acute, there is an acute condition that is going on in the body, such as in trauma, infection, or sudden or respiratory failure, or mechanical ventilation issues, pneumothorax, these things, or chronic, where your system is building up. So when your condition is chronic, that is when the renal compensatory mechanisms actually can work out, because it takes days for those to come into play. Therefore, in these instances, as in bronchial obstructions or tumors or bronchitis, bronchiectasis, those things, you can end up having chronic respiratory acidosis with metabolic compensation, which happens with the kidneys. So how do kidneys compensate? They will excrete more acids out. That is how they are going to compensate. Okay, respiratory alkalosis. So in alkalosis, you have more, what you have is more hydroxyl ions. So how are you going to get more hydroxyl ions in respiratory alkalosis? That is, now in the lungs, you're excreting carbon dioxide, which is actually giving rise to an acid. So what are you going to do then? You're going to excrete more carbon dioxide so that your system is now towards alkalosis, because you are expelling more acids. So here, you're expelling more acids, so your carbon dioxide level is going to go down and your pH will go up. So that means this is alkalosis, okay? So hyperventilation is the commonest cause of respiratory alkalosis, and you can end up having that in other pathological instances where the respiratory rate is increased, as in fever and anxiety, and also in cirrhosis. Why do you get increased respiration in cirrhosis? Anybody who can remember the reason? Basics? In cirrhosis, what is going to happen that will lead to hyperventilation? Yes. In cirrhosis, you are going to have ammonia that is not being detoxified by the liver through urea cycle. So you are accumulating ammonia, which will stimulate the respiratory center to hyperventilate and lead to respiratory alkalosis. Okay, so and tachypnea, pneumonia. So any instance which will lead to increased ventilation will lead to respiratory alkalosis. And if you are having respiratory alkalosis, how are you going to compensate? That is again through the kidneys, because if it's respiratory, then only the metabolic component can compensate. So here you will have to excrete more bicarbonate to help the situation, which is not very good, not very well done, and will take time, and usually not well compensated. Now, finally, metabolic alkalosis. So here, what is happening? If you are having metabolic component leading to alkalosis, there you have more bicarbonate leading to increased pH, right? So here you have more bicarbonate leading to elevated pH, and the reasons can be divided based on this interesting test, which is called response to the saline infusion. So how do you, what is the basis? The basis is based on the previous fact we talked, before, why you get acidosis in the absence of mineralocorticoids. So here, what is happening is associated with the extracellular fluid depletion. So if there is extracellular fluid depletion, you will have loss of sodium and water, which will stimulate RAS, and that is renin-angiotensin-aldosterone system, which will increase H+ and potassium excretion while retaining the sodium and water. So all of that is because of the action of aldosterone. Aldosterone would be excreting H+ and potassium when it wants to keep sodium, and water is kept along with it. And if that is leading to the alkalosis, because you're losing more H+, now you're losing more H+, this will respond to saline. Why? Because if you give saline, you're going to take the underlying pathology out, which is the extracellular fluid depletion. And if you're treating the extracellular fluid depletion by saline replacement, then this action will stop. This doesn't have to continue. And it will respond and come back to normal. So that's why it is called saline responsive. In this case, your urinary chloride would be less than 20. Why? Why urine chloride is low? Why would that be? That is because you're keeping sodium in this situation. Because sodium is kept along with chloride. You can't keep sodium alone. So your system is working so that you're retaining sodium and water along with chloride, and that is invariably leading to excretion of H+ and potassium, because you're keeping sodium and water, and leading to alkalosis because you're losing H+. So how you identify the situation is, differentiate. In differential diagnosis, urinary chloride would be low because you're not losing chloride. Saline, if the condition is saline unresponsive, it would be associated with the potassium depletion, and still it would be associated with sodium depletion. Potassium depletion, and urinary chloride would be more than 20, because the reason is because you're not having sodium. The reason is not because of loss of sodium and water. Therefore, the reason is not because of keeping sodium and water and excreting potassium and H+, and sodium and water is excreted in normal way. Therefore, your urinary chloride would be higher than in cases where it is saline responsive. So let's look at what are those. So loss of H+ due to vomiting and NG suction. Would these be saline responsive? Can anybody tell me whether these would be saline responsive? Yes. Vomiting. Would it be saline responsive or not responsive? In vomiting and NG suction, let's say vomiting, what is going to happen to the extracellular fluid volume? It's going to reduce. Therefore, this will be saline responsive. Now, in Cushing's syndrome, primary hyperaldosteronism, secondary aldosteronism, these instances, what is happening? Cushing's syndrome. Are you losing extracellular fluid? No, you are actually keeping extracellular fluid. So ECF is increasing more because you are having excess cortisol. Not necessarily like, not to the level you are going to have edema, but it's not affected. ECF is not affected. Therefore, these are not going to be saline responsive. Okay. And it can be also due to parenteral treatment or oral treatment. And also antacids can also lead to the same problem. So how are you going to compensate metabolic acidosis? If it's metabolic, you have to compensate by respiration. So how are you going to compensate with respiratory mechanism? That is by keeping more carbon dioxide. So how are you going to keep more carbon dioxide? That is by reducing the respiratory rate. Can you go on doing that forever? No. So therefore, it's going to be limited at one point. So you can do it to a certain extent, but not forever. So you need to understand how these compensatory mechanisms come into play in each instance. Now, let's see how do you interpret AB chain. Now, arterial blood gas analysis, specimen collection is very important. Why? Because the specimen has to be brought to the lab with care so that the acid-base status is not changed after taking the blood or after taking the blood out of the patient. So how do you maintain that? That is by transporting it in melting ice without any air in contact with the blood. So you take the blood into an anticoagulated syringe, usually heparinized syringe, and that blood is usually taken from a femoral or radial artery, and eject any air bubbles in the syringe immediately and close the cap and transport it in melting ice so that you can do the analysis immediately. So what are the steps? Now when you go to the blood gas analyzer, so there you have electrodes to measure the main components, and some certain parameters are calculated, but certain parameters are measured. So it's okay, you don't need to remember which ones are calculated and measured, but they are measured by electrodes by the blood gas analyzer. So when you look at an ABG, what are you going to look at first? How do you interpret? The first step is to understand what's happening with the pH. So same thing, what's happening with that pH? Is the pH increasing or decreasing? If it is increasing, then you identify it as alkalosis. If it's decreasing, then you identify as acidosis. Okay, now you know what is happening with the patient, whether you identify whether it is acidosis or alkalosis. Once you identify that, then you have to understand which component is contributing to this acidosis or alkalosis. Now, if it is, how do you work that out? So as I said before, pH is directly proportional to the metabolic component, whereas indirectly proportional to the respiratory component. So first, you can look at the respiratory component. If it is going against the pH, then it is not the component that is contributing to the pH. Or if it is going with the pH, then it is the one that is contributing to the pH. So if the pH is increasing, then the PCO2 should also be going with the same track, but PCO2 should be decreasing. If the PCO2 is decreasing, then the pH should be increasing. And if this pattern is seen, then you can see that the reason is because you're having the respiratory component contributing to the pH. And if the pH is decreasing and the PCO2 is also contributing, that means PCO2 is increasing and PCO2 is increasing and pH is decreasing, then it is the respiratory component. And then you look at the bicarbonate. Is the bicarbonate the metabolic contribution towards the acidosis or the alkalosis? So look at these two components like this so that you can identify which component is contributing to the current pH. So that is how you identify which component is contributing to the acid-base disorder. Because when you first you identify whether it is acidosis or alkalosis, then you identify which component contributing to the acidosis or alkalosis. And then you need to understand whether the other component is helping out with the situation. So if it is acidosis, then if it is contributed by the respiration or respiratory acidosis, whether the metabolic component is helping out. So this part we have already discussed, which is actually going with the pH. Then you identify whether it is respiratory or metabolic. And so the other one, whether the other component is going the opposite direction. So if your pH is decreasing and your PCO2 is increasing, that means your CO2 is helping the pH. So the respiratory component is the one contributing to the pH. In that case, if the bicarbonate is going the other way, so where should bicarbonate go? It should increase. Why? Because it should help the pH to come back to the normal level. So it's decreasing, it has to come back to the normal level. If you want to come back to the normal level, then your bicarbonate need to be increasing to bring it up. So like that, you need to look at the other component, whether it is going the opposite direction to the pH to see if there is any compensation. So if it is going towards the opposite direction, even if the pH has not come to the normal level, then there is some compensation. So if the pH has not come to the fully normalized, then it is partially compensated acidosis or alkalosis. If the pH has come back to the normal, fully come back to the normal, then it is fully compensated alkalosis or acidosis, which is very rarely happening. Usually it's partially. Or uncompensated, where it is not going the opposite direction. So these things you need to interpret when it comes to the ABG and also for the exam. Okay. So another thing is you can have mixed acid-base disorders where two things are coming into play. So you can have respiratory alkalosis and metabolic acidosis happening together. A very good example is, one is salicylate poisoning. Another good example would be liver failure, where you're having elevated ammonia level leading to increased respiratory rate. That will cause respiratory alkalosis. But because of the liver failure, you're having lactic acidosis and metabolic acidosis happening as well, which is also contributing to the final result of pH. So there you will see both components playing together. So most of the instances, this is what you're going to see, mixed disorders. So there, how you identify is by first going through the pH and then looking at the PCO2 and then looking at bicarbonate and identifying which is going in which direction and looking at it logically. Okay, so that is it for how you interpret ABG. So let's see whether you can interpret these two ABGs. First one, who would like to try? What is the pH that you see here? In the first question, pH. Can you interpret the pH? What is happening with the pH? Has the pH increased or decreased? Decreased. Good. So if it is decreased, is it acidosis or alkalosis? If the pH is decreased, acidosis or alkalosis? Very good. It is acidosis. So now you look at the PCO2. First step is looking at PCO2. What is PCO2 doing? Is it helping the acidosis? What has happened with the PCO2? Is it increased or decreased? Yes. CO2 has increased or decreased? Increased. Very good. Okay, very good. It is, can you say compensated respiratory acidosis, dear? So there is an answer as compensated. So let's go through the whole thing and we'll come to your answer. So it is increased. So when PCO2 is increased, is it helping for the acidosis or going against acidosis? CO2 is increased now. It is. Is it contributing to the acidosis or not contributing to the acidosis? Helping. Very good. So it is contributing to the acidosis. Therefore, we can identify this as a respiratory. It's a respiratory acidosis. Okay. So this is respiratory acidosis. So I'm going to write AC for the acidosis. And actually, I can type. Yeah. So this is going to be, therefore, this is going to be respiratory acidosis. Now let's look at what is happening with now we have identified respiratory acidosis. What is happening with the bicarbonate? What's happening with the bicarbonate? Bicarbonate is, yeah, it's not helping, is it? It's at 24, so it's not ideal. It should be increasing to help, but it's not helping. Therefore, it is not actually compensating. Therefore, this is actually uncompensated or non-compensated, uncompensated respiratory acidosis. Why? Why? For your metabolic component to compensate, you need some time. So this is actually happening too fast. So that's why your compensation is not good enough, or it's not happening at the moment. Okay. So let's look at the next one then. Why is it too large? Okay. So let's look at the next one. What's with the next one now? So what's the pH here? Is the pH increased or decreased? What's with the pH? Is it acidosis or alkalosis? Very good. It's acidosis. So we identify it as acidosis. So what is this acidosis? Let's first look at the CO2. Is CO2 contributing to the acidosis or not? CO2 is 32 millimoles mmHg, 32. So is it contributing to the acidosis or not contributing to the acidosis? No, very good. So therefore, it's not the respiratory. Then we are going to look at the very good non-compensatory metabolic acid. Let's see. Okay, so let's see whether it is non-compensated. Okay, very good. You're partially compensated. Yes. So why? Why do we say that partially compensated? So we look at the metabolic component next. So bicarbonate is decreased. So it is actually contributing to the acidosis. Therefore, this is going to be metabolic acidosis. And then we go and look at the other component again, CO2. CO2 is it decreased or is it normal, decreased or increased? It is actually CO2 is actually increased or decreased or normal. Yes. CO2 has CO2 done nothing? It is decreased. Very good. So CO2 has decreased. When CO2 decreases, what is going to happen? It is going to cause alkalosis. Therefore, the respiratory component is actually trying to compensate. So there is respiratory compensation happening. But is it complete? Has the pH come back to the normal? No, pH is still acidic. Therefore, it is partially compensated metabolic acidosis. So that's how you work out the ABG. Okay. Okay, so we started 15 minutes late, so we are going to end 15 minutes late. I hope you understood how we are going to interpret the EBG. And so we'll meet again next in 2 days. Yes, Thursday with the next lecture. Okay. Okay, thank you and goodbye until we meet. Okay.